Hello everyone and welcome to the first NCAAD Quality Improvement Workshop. It's great to have you all here. My name is Natasha and I'm a Clinical Audit Project Officer to the Audit and one of the hosts for today.
Hello, I'm Naomi. I'm also an officer on the Audit and I'm hosting today as well.
Can I just check that everyone can hear me okay by asking you to type hi into the chat box. It should be on the far left of your toolbar. Great. Hi Varsha, hi Sen. Lots of hi, thank you. So just to say, we really appreciate all of your attendance today. We know that due to the COVID-19 coronavirus, it's been quite difficult and work priorities are changing quite a lot. So again, thank you for your time and coming in. And as a result, we will be doing this remotely. We sort of plan this a little bit differently in terms of the hosts and panelists. But yeah, thanks again for coming.
Yeah, thank you for that. We're also, there was just no capacity to do it later down the line because we appreciate it would have been better a bit later on, but we are recording the video. So for anyone whose colleagues couldn't come, or if you want to watch it again, we will have it all online on our website.
Yeah, thank you. So today will be an interactive 1 hour session for you to get the most out of your NCAAD results and hopefully kickstart some QI planning within your trust. So it doesn't matter whether you attended a workshop and have an ongoing project, or you're quite new to this and you just like to find out some ideas. It's great for you to join us and just get some, have some sharing and learning with your colleagues. Just to give you an idea also, we will be recording the session, including the video, audio and slides, and that's so that we can upload this onto Knowledge Hub for all of your colleagues to see.
Okay, so we have 4 speakers with us today who will help facilitate. The first is our NCAAD QI experts, Maureen McGeorge. I'll just see if Maureen's here now.
Hi.
Hello, Maureen.
Hi, everybody. Lovely to be here today. I sure probably met some of you at the workshop, so very glad to be here with you.
Right, that's great. Thank you very much. And we've also got David Baldwin. Are you there, David?
I am. Thank you very much. And hello, everyone. It's really nice to be involved in this today. Thank you.
Thank you for joining us, David. And we've got Dr. Lorna Farquharson from the University of East London.
Hi, everyone. Thanks for joining us today. It's great to be part of this webinar.
Thank you, Lorna. And finally, we've got Dr. Sen Kallumpuram, also from the East London Foundation Trust.
Thank you.
Are you there, Sen?
Thank you. I'm really glad to join the event today with you, webinar.
Thank you very much. And we'll hear more from all these speakers very soon.
So just to get everyone involved and interactive as possible, there's a few functions you can use as attendees. The first one being the chat function. So you'll see this on the far left of your toolbar. So if you click this, you can use the text box to say hi to your colleagues as you have done already. Perhaps introduce what trust you're from or what you're hoping to get out of today. We also have a raise hand function, and we're encouraging you to use this right towards the end of the webinar. We'll have a Q&A section, and using that you can raise your hand and we'll be able to activate your microphone, and then you'll be able to voice your question over the mic. So simply press the hand to raise your hand and press it again to lower it. We also have the Q&A chat where you can use the Q&A to type in a question into the text box. So we'll be able to answer those questions live. So our QI expert, clinical advisors, or Sen, our QI case study, will also be able to answer your question live. And finally, we'll have some QI polls throughout the webinar. So these will simply pop up at each interval and you'll be able to cast your vote. And we'll be sharing the results after each poll shortly as well. So that's a quick rundown of all of the functions that you can use today. So please do use all of those to make the most out of the session.
Okay, so for a quick overview of the agenda for today, we're going to start with the Core and Spotlight Audit Results Summary. That will be led by our clinical advisors to the audit, that's Lorna and David. And then we're going to have an introduction to the model for improvement. That's by Maureen, our QI expert. And then we've got 2 QI case studies, one from Dr. Sen Kallumpuram and one also from Maureen, and they're about care planning and reducing waiting times. And then at the very end, we're going to have a large Q&A where you can ask any of the questions that you need to ask for any of our panelists, and that will be for all of us to contribute together. So now we're going to go over to David for an overview of the NCAAD core audit results.
Thank you very much, Naomi, and hello again, everyone. You'll remember the audit and the fact that it was conducted almost a couple of years ago. But just to remind you, this was an audit of inpatient care of patients with a primary diagnosis of anxiety or depression, aged 16 or above, within NHS facilities. And the reports from the audit were published in the autumn. And you'll remember that there was a sort of a user-friendly report and then a more detailed technical report. The user-friendly report was actually designed in collaboration with users and carers, the idea that it was being very readily accessible to as wide an audience as possible. And we put a number of key findings from the audit and then a number of key recommendations. And you'll remember that before the audit was started, we identified a number of standards, 13 standards in all, and these were grouped in particular domains. So the domains related to access and assessment, to shared decision making, psychological therapies, outcome measurements, and discharge. And for each of these domains, a small number of findings were identified as the key findings. And then obviously the recommendations follow on from those findings. So if we think first of all about access and assessment, so this really relates to the beginning of clinical care, usually at the time of someone's admission to hospital. And we found that some quite key information was actually not being recorded routinely in a significant proportion of assessments. Now, this related to parameters such as physical health, but also actually to demographic information, to comorbidities and a history of trauma, and quite surprisingly, to whether there was evidence of a note relating to previous psychological or pharmacological treatment. In terms of decision making, we looked at care plans in detail and whether or not service users had a copy of their care plan. So we found that 91% of the service users did indeed have a care plan, but actually in a number of these plans there was rather little evidence of shared decision making with the user themselves. Also, a significant minority actually didn't have a copy of their care plan, and that routine information was not being shared with users and with their carers as much as it should. Psychological therapies, we looked at the proportion of service users who were being referred for psychological therapies and the nature of that therapy, and also whether it had started. And we found, I think, quite a surprising finding, which was that actually only a minority of the service users had been offered a psychological therapy within the period of the audit. We'll hear more about that in more detail later, because this became one of the focuses of the spotlights of the overall audit process. We also looked at outcome measurement, whether or not scales were used either at the time of admission or following on towards the end of someone's discharge, to see if actually people were using reliable measures to assess change. And only a small minority of service users were being assessed with an outcome measure, and it was very rare indeed for a service user to have been assessed twice using the same measure. And then we looked at the process of discharge, so a number of facets such as the timing of discharge, the degree of planning, and of course post-discharge arrangements such as the liaison with GP and what was included within the information. And we found that a majority of people had received a follow-up after discharge, but a significant minority, some 26%, didn't actually have a copy of a crisis plan at the point of discharge. And again, a significant minority of the service users had not been given sufficient notice of their discharge. So these were the key findings, and of course from the findings come the recommendations. So if we move on to the next slide, please. Thank you. So you see we make a number of recommendations. Now, there are recommendations for each of the domains, and sometimes these relate to overall trusts, and sometimes to service managers, or finally to individual clinicians. So, for example, for the access and assessment domain, you'll see that we're making a recommendation relating to NHS Trusts. So we recommend that trusts should provide effective systems that enable clinicians to routinely collect and record key information from all service users so that appropriate care plans can be developed. For shared decision making, you note that we make a recommendation relating to individual clinicians, but also to service managers. So for the clinicians, it relates to care plans, and that these plans are developed collaboratively with the service users, and that the service users are given a copy, and also that the carers of those service users are provided with information and support, and also offered a carers assessment, because only a small proportion of carers had been offered an assessment. And then we make recommendations relating to service managers. So this is to do with reviewing at the service level the involvement of carers in accordance with best clinical practice, and also to ensure that information about medication in particular is made available in a variety of formats which are readily accessible to all service users. In terms of psychological therapies, we make recommendations regarding clinicians and also to trusts. So for trusts, we're recommending that individual trusts investigate quite why the referral rates were so low, and to explore how that could be addressed. And also for the individual clinicians, that we should be offering psychological therapies in accordance with NICE guidance. For the outcome measurement, again, there are recommendations for the clinician and for the trusts. So for the clinicians, we're recommending the routine use of outcome measures. Now, for example, for this particular inpatient population with anxiety and depression, it could be as simple as using, say, the GHQ, the GAD-7 or the PHQ-9, because these are used so regularly in IAP services. But obviously that would need to be decided at a local level. And that's why we make a recommendation for trusts about which outcome measures can be used to reliably evaluate change and the effectiveness of treatments which have been provided. And then finally, we make recommendations relating to discharge, again for both clinicians and trusts. So for trusts, we're recommending that the individual trusts review their systems for ensuring discharge letters that are sent promptly to general practitioners, so primary care services, within 24 hours. And as for the clinicians, we're recommending that all service users, and where agreed, their carers are offered at least 24 hours notice of discharge, that crisis plans are developed jointly, and that they're in place at the point of discharge, and that all service users are followed up within 48 hours, recognising that the period immediately after discharge from care can be very unsettling for many patients with anxiety and depression. So thank you very much. Thank you.
Thank you, David. We're now going to hand over to Lorna, who will be going over the psychological therapy spotlight results. Hello, Lorna.
Hello, and thank you for handing over to me. So picking up on the Spotlight Audit key findings, I'll firstly just outline that the Spotlight Audit report was published at the beginning of this year, and acknowledge really it's the first time that we've had an opportunity to discuss the findings in relation to developing quality improvement plans. And the Spotlight Audit of psychological therapies focused on secondary care psychological therapy provision for adults, including both inpatient and community services. And the findings that we had, firstly, that access to psychological therapies was poor, with getting close to half of those included in the audit waiting longer than 18 weeks from the point of referral to starting therapy. So only 59% being seen within the target timeframe. For appropriateness of therapy, we looked at the extent to which the type of therapy provided for the main presenting problem was in line with NICE guidance. And in this area, we found that 65% were receiving a type of therapy in line with NICE guidance. For service user involvement, we found when we analysed the data from the service user survey, quite a lot of positive findings really in this area, with 75% of respondents agreeing that the type of therapy helped them to cope with their difficulties, and also the vast majority rating their therapist very highly as well. So some very encouraging findings in that area. Moving on to therapist training and supervision. For supervision, the vast majority of respondents to the therapist survey said that they were receiving formal supervision, but we had 3% who were saying that they weren't receiving any formal supervision. And a large proportion of therapists reporting that they were providing at least one type of therapy with no formal training. Now, the really important things to take into account when interpreting these findings, we are aware of some issues with the distribution of the therapist survey, and in at least one trust, it went to a wider range of professionals than was intended. And also with therapist training, there are lots of contextual factors that need to be considered when interpreting these findings, and we do clearly outline those in the national report, and it's also important to be considering that at a local level, supplemented by the local knowledge as well. For outcome measurement, David's already talked about outcome measurement in relation to the core audit, and in this spotlight audit, we found that 50% of cases had evidence of an outcome measure being used at least once during therapy. But if we think about how we use measures to evaluate outcomes, it of course needs to be used on more than one occasion. And when we looked in more detail at this area to see what proportion were having evidence of an outcome measure being used on more than one occasion, this percentage drops down to 34%. So I'll move on to the recommendations at this point. Similarly to the core audit, we had recommendations in relation to each of the standards, but our principal recommendation is that all trusts should have a trust-wide psychological therapies management committee. We made recommendations about the constitution of this committee and also the tasks that should be undertaken. So in terms of who should be included in the committee, the importance of having service user and carer representatives, also the lead psychological professionals for the trust, and ensuring that this has direct representation at board level. And the remit of this committee, the importance of coordinating some of the key tasks that would enable improvements. So looking at systematic data collection, ensuring that there's close monitoring and management of waiting lists, finding ways to agree and implement more routine outcome measurements, and building in service user involvement at all levels of the work, being able to look at care pathways and follow up and ensure that therapists providing therapy have the appropriate training and supervision in place.
Amazing. Thank you, Lorna and David, for giving us the highlights and recommendations from each of the audit reports. That was really great for those. We next have a quiz coming up just before we get onto our QI case studies. So we'll just launch that on your pages now. You should be able to see this on your screens. The question is, quality improvement as a philosophy assumes that A, most problems with service delivery result from process difficulties, not individuals. B, frequent inspection is necessary to improve quality. C, employees generally try to avoid work. Or D, that top management leads all quality improvement activities. So quality improvement as a philosophy assumes that ... Please cast your votes now. I'll just give you a few more seconds to get those in. Yeah, absolutely, I can read that again. So quality improvement as a philosophy assumes that A, most problems with service delivery result from process difficulties, not individuals. B, frequent inspection is necessary to improve quality. C, employees generally try to avoid work. Or D, top management leads all quality improvement activities. Great, we've got a few votes in the chat as well for B. So we'll just share those results now and see what we've got. Wow, okay, so let's have a look. So we've got 71% of people have said that quality improvement as a philosophy assumes that most problems with service delivery result from process difficulties, not individuals. 21% have said B, frequent inspection is necessary to improve quality. And we've got 7% have said C, employees generally try to avoid work, and no votes for D, top management leads all quality improvement activities. So Maureen, our QI expert, would you be able to give us the information about the correct answer and why that is?
Yeah, of course. The large majority are correct, so the correct answer is A. I think this is it kind of links to the whole bad apple theory, the idea that it's actually individuals that give us the problems and compromise our quality. Quality improvement recognises that usually it's about systems and processes, and that we need to make changes to those systems and processes to bring about improvement. Those that answer question B, frequent inspection, maybe they're confusing inspection with measurement. Inspection per se tends to be more of a quality assurance method rather than quality improvement one, but sure, we use ongoing measurement in the context of quality improvement work, but it's not inspection, it's measurement for improvement to show that we're actually bringing about improvement. So yeah.
Okay, thank you.
Maureen. Yes, so now we are actually going to go back to you, Maureen, for our introduction to the model for improvement.
Thank you. I've been given the invidious task of a 10-minute presentation on the model for improvement, so whistle stop it will be. I'm sure that you're all familiar with the model for improvement. It's sometimes referred to as the 3-question model. So we could go on to the next slide. So it looks at 3 different questions. First of all, what is it we're trying to accomplish? This is really about trying to understand what you want to get out of the work. The second question, how we know changes and improvement, that bit's about measurement. The third is the easy one, so it's what changes can we make that are going to result in improvement. And the reason it's easy is because we're constantly being told in healthcare to think about solutions, not problems, and we tend to jump to that. So this is a kind of refreshing approach that allows us to kind of come up with our hunches for changes. And then once you've kind of set up the measurement for that, you can then start to test out small scale cycles of change using the Plan, Do, Study, Act cycle. So we're just going to drill down into each of those questions, into the PDSAs in a little bit more detail now, using case study example. So if we have the next slide, please. So question 1 then, although it kind of sounds straightforward because we're trying to accomplish, really there's 3 different tasks in there. So the first one is defining what the problem actually is, and quite often we don't spend enough time on that, really understanding what's going wrong, because unless we do understand what's going on fully, then we could go try and fix something that isn't broken. So in order to try to do that, we need to do a bit of diagnosis using a variety of different diagnostic tools, whether it's things like looking at existing data or brainstorming. And it's only really then, once we really understand our problem and what's causing it, that we can start to formulate an aim about what it is that we're going to try and do to improve it. So if we move on to the next slide. So if we think about an example that might have come out of your audit findings, care plans do not contain information about experiences of previous trauma. So that's a straightforward problem. We know it's a problem because it could have major knock-on effects for the care plan that we do for our resident inpatients. In terms of diagnosis and analysis, at this point in time, we don't really know what's causing the problem. We can only second guess that. So perhaps what we might start with would be taking a sample of case notes from the wards to understand whether it was a general problem or one that was specific to one ward. It's always a temptation when we're doing improvement work to try and work everywhere at once, and it doesn't generally work that way because it's capacity issues and other factors. So you might then identify that there's a couple of the wards where it seems to be more of a problem than in other areas, but that actually Ward 3 is the one that's really keen to do something about it. So you might then have a brainstorming session with the staff saying, okay, we've got this problem, people aren't doing identifying whether or not people have had previous trauma. Why do you think that is? And what might come out of that might be that staff feel unconfident about discussing previous trauma because they're scared about re-traumatizing people. So now you kind of really understand why it's not happening. It's not because they can't be bothered, it's not because they're not recording it, it's actually because they're not confident. So you can then start to think about the aim of the work. And the aim might be to increase percentage of service users on Ward 3 that have a history of trauma assessed and recorded with the next days of admission. And what you're looking at here is the kind of making sure that the whole thing is smart and doable. So you're specifying where the work's going to take place, with which group of patients, and when you would expect the assessment to be done by. So that makes the whole thing measurable. So it's an operational definition there that we're talking about. So moving on to the next slide then, this is going to take us on to the second question. So the measures in improvement are allowing us to see whether or not the changes that we're testing are resulting in the improvements that we're seeking. And generally there are 3 types of measurement that people use. There are outcome measures, those relate back to the aim. There are also process measures, and process measures are really about what parts of the system that's creating the outcome are causing the problem. So again, diagnosis will help you to understand better. So in our example previously, we weren't getting the assessments of previous trauma done because of the staff not feeling confident to do it. So that was the bit of the system, if you will, that was broken. The third part is your balancing measures, and your balancing measures are really the kind of what ifs. So they're the kind of measures that you put in place if you're going to do a piece of work and people are concerned that there are going to be unintended consequences. So a very obvious example would be, we want to decrease length of stay, yeah, but what if we increase readmission rates within 28 days? So you'd measure that just to reassure people and yourself indeed that wasn't going to happen. Okay, so if we move on to the next slide then, so this will give us the example. So the outcome measure for in the case of of assessing for previous trauma might be the percentage of service users on Ward 3 that have their history recorded and assessment recorded with the next days of admission. And that's likely to be a weekly measure because it's unlikely to be having enough daily admissions for that to be a daily measure. So if we go on to the process measure then, as I've already indicated, the part of the system that we identified as broken through diagnosis was the staff confidence levels. So you'd have some kind of measure relating to experiential staff confidence to assess for previous trauma. In terms of balancing measure, the staff were saying quite loudly that they were worried about re-traumatizing people. So I'd be inclined to measure for that as well. So yeah, okay. So if we move on to the next bit. So this is the change ideas then. We're going to come back to run charts in a second, which is the way that we collect our measures and visually show them. But change ideas, now they're kind of an interesting bit. And as I said at the beginning, they're the easy bit, they're the exciting bit, because everybody's kind of has loads of ideas about how things can be improved. But if you don't, then just because there's a nice guideline doesn't necessarily mean people are doing it. So there may be an evidence base as to what good looks like. That could be then, you could then be testing ways of getting people to adhere to that guidance. It might well be that there are other services tackling the problem and you can borrow their ideas and test them at your own service. Or it may be that people within the team had worked in previously in other services where things work much better. And just the thing about adapting and not adopting is that it's very seldom the case that we can blindly just take something from another place and embed it in our practice. We have to kind of localize it and work out how it works for us. So moving on to the next slide then. Just to kind of, people sometimes get confused between the difference between a change idea and a PDSA cycle. And just kind of in essence, really, then a change idea is the what you want to do, and the PDSA is the how you want to do it. So in the example that we're working with, the change idea is about getting people, staff, to actually undertake the assessments, but how we get them to do that is something that we'll need to be looking at. And there's a number of different change ideas. So people might say, well, a great kind of what might be, let's give more training. You still then got to work out what that training looks like. It could equally be the what might be, we need to introduce some special prompts for staff supervision to encourage supervisors to work with staff around developing those skills with them. So again, the PDSAs would be the how, the detailed planning of how you then go about testing it out. Okay, so the point about the what can you do by next Tuesday is the IHI kind of sort of really stressed the point that it's rapid cycles of change. So it's not planning in the kind of the sense that we conventionally understand it in healthcare, where you're kind of taking ages working things out in an awful lot of detail. It really is kind of having a hunch about what's going to work and trying it out. So your best bet about what's going to work. And in my experience, things are generally led from the top, and the people that are really know best, who are doing the job, really have some great ideas. So often you don't need very many cycles of PDSAs to work out what the how is. Okay, so if we just move on to the next one. So as I said, in the example of staff training, if staff training was the intervention to try to increase staff confidence, you don't know what that training looks like. You don't know how to do it. It could be face-to-face, it could be online, it could involve shadowing, it could involve role play or simulation. You don't know how long the training needs to last. You don't know whether staff need preparation or indeed follow-up pre or post the training. So there's lots of question marks there, which is why you can't just go ahead and implement an action plan, because somebody sat in a darkened room designing a training program isn't necessarily going to get the best results first time around. So this is kind of small scale rapid cycles of change. Okay, so if we move on to the next slide then. So just to kind of, and that's, yes, so the next, so thinking about the example then of how it might look. So if you're going to try and develop training, so the planning might be, okay, we think we're going to be best having a face-to-face session. We think our ward manager should deliver a 1-hour session to 4 staff at the end of the shift. Mix of didactic input, but also role play. So the doing is, they went ahead with it, although realised that they were running out of time towards the end, so it did feel a bit rushed. So then you've got the study bit. So what you realise is the didactic session was well received, everybody liked that, but a couple of people felt uncomfortable doing role play. 2 out of 4 is quite a big percentage, so that's, you know you're going to have to tweak something there. Everybody felt tired, it was the end of a long shift. Confidence levels to assess increase slightly, so you're on the road, but you're not really getting it quite right yet, so you're going to have to adapt it. So then your act bit is where you work out what you're going to do next. So the tweaks that you might make might be, say, okay, we're going to deliver the same training at the beginning of the shift rather than at the end of the shift, and people will be observing a simulation rather than doing a role play. And actually, we're also going to add in a bit of shadowing with a very experienced colleague post-training, just to kind of ground the learning from the session. So that's kind of hopefully illustrated the sort of speed of it all. And as I said, I was going to bring you onto a run chart. So we use run charts in order to kind of plot progress over time. So your axis is always, or generally, the large majority of the time is over time. And what this run chart shows is that you set up your baseline, which means that about 18%, the red line there, the first red line, about 18% of service users were having previous trauma assessed. So there were 4 different cycles of PDSAs where you continued to work along that same level of performance. But it was PDSA 5 was the one that then led to a step change, and you had to then readjust the median. And at that point, you were looking at about 48% of service users having trauma assessed. So whatever you did with PDSA 5 was the one that worked. And obviously in 10 minutes, I haven't got time to go into the run chart rules, but the next slide shows in summary what those rules are. So fantastic, very easy to read article that explains the science, the stats behind using run charts. Okay, so just to kind of start to wind up a bit now, some hints and tips. So if you're going to be running an improvement project, really good idea to start off with quick wins, just to kind of get people engaged and get them realise that being listened to and that the improvement can be made. And you've got something as visual as a run chart. That's a great way of enthusiasing people. So, and also working with people who are keen. So they used to sort of say with improvement work, if you can get this as people that are resistant, but that's not the kind of thinking now. So don't be too ambitious. We worked with one word there. Try to use existing data or make it easy to collect. Make your run charts visible, and really importantly, when people start to get successes, which they often will quite quickly, celebrate with them. So moving on to the final slides, just remember, if you know what you need to do and how, or you don't need to do an improvement plan, you just need an action plan. If you know what you need to know, but not how, you will need an improvement plan, because you'll need to use PDSA cycles to try and work out exactly how to do it. If you're not sure about what and you're not sure about how, you need to do a bit more digging with the diagnostics to actually work out what's going to work best. Here's a link finally to some training that was developed in Yorkshire and Humber at the Improvement Academy there. So it's e-learning, and all you need to do is register to access it for free. So if you've got colleagues that want to get involved with this work who haven't been able to access training, it takes a couple of hours to complete. So thank you very much for listening.
Right, that's wonderful. Thank you, Maureen. We're just going to check now for any Q&A questions on that. I can see that we've not had any come through yet, but if anyone's got any questions for Maureen, and you want to wait a bit, you can put them in now and we'll go over them at the end in the Q&A section. And there's no questions in the chat either. Okay, so let's go on to our next quiz. Here it is. And the question is, when is it appropriate to collect and use data? A, before the QI project to prove a problem exists. B, during the QI project to answer questions about the cause and help prioritize the implementation of improvements. Yeah, I can see it's not launched yet. Just one moment. I'll keep reading them anyway. C, after the implementation of the improvement to maintain the gain. And D, all of the above. For some reason it's not launching. Let me try again. Okay. Are people still not able to see it? No. Okay. I'm going to read it again. Okay. So the question is, when is it appropriate to collect and use data? So A, before the QI project to prove a problem exists. B, during the QI project to answer questions about the cause and help prioritize the implementation of improvements. C, after the implementation of the improvement to maintain the gain. Or D, all of the above. Okay, yeah, sorry that's not come up. I don't know what's happening there. But I can see there's lots of people saying all of the above or D. Yeah, sorry about that. I don't know what's happened. And let's hand back over to Maureen to see the right answer.
Yeah, absolutely. Everybody's correct. All of the above. So people are clearly familiar with measurement for improvement. When you're starting out a piece of improvement work, you have to have baseline data with some degree of variation in the number of data points, but 10 is a kind of a sort of a general accepted rule. So 10 data points allow you to understand how your current system is operating before you start testing the changes. Then you're using measurement on an ongoing basis to find out whether or not the changes that you're testing are leading to improvement. And even once you've got to your level of performance that you're seeking, it's a good idea to perhaps reduce the frequency, but still measure to make sure that you're maintaining your gains.
Great. Okay, thank you very much. So next we've got our first case study from Dr Sen Kallumpuram from East London NHS Foundation Trust. So I'll hand that over to Sen now.
Hello, good morning everyone. It's a privilege to join the webinar today. I would like to do a little presentation of reducing the waiting times, which we did as a QI project for our Luton memory services. The team who was involved was myself, my colleague, Dr. Schumann, Janet Fuller, Claire Warren, Bridget, Rachel, and Hetal. And we had the coach, Anna Smith, and sponsor, Dr. Farid Jabbar. Why did we choose this project to begin with? Was because this was the first ever QI project we did. We initiated the project in 2016 because we found that the waiting times for the Luton memory services was over 10 weeks duration. So when a referral is made by the GP to our services, we kept initially for a while until we got all the information from the GP, and then we did the CT scan request and then was assessed by one of our clinicians, and then if needed a neuropsychology assessment or occupational therapy assessment was organized. So once we understood the process, we thought we should actually join the QI and make changes so that we can understand what the problems were in the processes which we were doing, and corrective measures could be put in place. So it took a year and a half to complete the project. We completed the project by the end of 2017. So initially when we did the audit, we had about 72 days of waiting time from the start of the referral to the finish of the referral. By the end of the study, we had 36 days. That is the significant, almost half of the initial start of the number of days. So the problem has been described in this slide. I'm moving on to the next slide, please. So to begin with, what were the challenges and barriers the team experienced? We had the lack of knowledge because no one of us had any training about QI. So all of us went initially for the pocket QI, and then most of us joined for the IHI training, which was a wave 5 training at the East London Foundation Trust. So all of us got trained in doing the QI project, about understanding about PDSA cycles, understanding about what needs to be done in terms of outcome measures and process measures, which we all had some understanding of. And also to some degree, we got understanding about the run charts. And what was the impact the QI project had on the services. So the lessons we learned through the process, through the QI project, was shared across the whole of Bedfordshire. So that was the impact of the QI project. Second thing is, as we said, we have reduced our waiting times to between 4 to 6 weeks now from the initial assessment. So patients are seen earlier. So patient satisfaction is better than how it was before. What was the relevance of the QI project for the service users? So it's clear that timely and early diagnosis empowers the patient and reduce the chance of them ending up in crisis. And we also understood that we could continue or translate those things which we learned across Bedfordshire, and patients from other areas will also benefit from the study or the QI project. We also formalized the ADL questionnaire, which means the activities of daily living questionnaire. Thus, it reduced the need of routine use of occupational therapy assessment for the initial assessment. Next slide, please. So, driver diagram, which we initially formulated, was changed several times, mainly because the number of change ideas were, initially we thought of was on a significantly high number, and we had to reduce it over a period of time. And we were learning as we moved on with the driver diagrams. Can you go for the next one, please? So these are the aim, as we already said, to reduce the initial assessment to 6 weeks. That was the first or the primary aim of the study. The primary drivers were the referral to management. Then we had the initial assessment, the individualized pathway, and feedback, follow-up, coordination, and administration as primary drivers. If you move on to the next slide, please. So as you can see, our driver diagram changed. These are the primary drivers, secondary drivers, and the change ideas. All of them we couldn't implement in terms of the change ideas, but when we did the PDSA cycles, the most important ones we were able to implement, so that after the implementation of the PDSA cycles, there was an impact to the waiting time. So first and foremost was making sure the GP referrals were appropriate. For that, what we did was we wrote letters to the GPs informing them about our referral criteria. So we left then for 3 months to see whether the referrals now contain the information which we required for the memory services. And we did complete the cycle by sending another set of letters to the GPs after auditing the first set of referrals which we got. We took only a few samples of the referrals so that we had some, we call it snapshot or the small PDSA cycles, so we could complete it quickly and then reiterate to the GPs through another set of letters, another wave of letters to the GPs, all addressing the same problem again. We also met with the GPs on a couple of occasions to inform them about the criteria, and they could respond to us with all the information so that the waiting times could be reduced. The second was to incorporate 2 community psychiatric nurses to the initial assessment process and a dementia nurse, so that we could do the initial assessments quickly, because initially we had only 1 clinician doing the assessment. The third one was, as I mentioned, improving the communication to the CT scan department so we get the scan reports quickly. We also did the ADL questionnaire, which I mentioned before, and we went through the process of accepting the ADL questionnaire as a part of our routine assessment. Can you move on to the next one, please? So PDSA cycle, I haven't put all the PDSA cycles onto the system here, but you could see one of them just being the process being mentioned. Can you go for the next slide, please? So you could see that from the referral pathway till the outcome, we have made a complete or a flow chart. So we could do our PDSA cycles to begin with, as I said, with the GP letters. Then we had the initial assessment by the screening by the 2 nurses, and then we went to the acceptance of the other processes. Can you go for the next slide, please? So the run charts were done after the initial assessments were put in place and after the PDSA cycle of the ADL questionnaires were completed. Go for the next one, please. You could see the run chart, and the run chart shows that the waiting times have decreased significantly to begin from the beginning, except there were few outliers which were all shown in the top end of the sharp peaks in the run chart. Next one, please. So the measures were, as I mentioned before, the waiting times were reduced to the CT scan heads, occupational assessment and neuropsychological assessments were reduced. Introduction of initial assessment by specialists, nurses and CPNs also helped in reducing. We did patient satisfaction questionnaire after the implementation of change ideas. We also did GP satisfaction questionnaire as the end of the test. Next one, please. So the learning is, we understood that it is possible to make significant changes in the quality of care we provide by making simple practical steps with short PDSA cycles. We were not able to, do a lot of change ideas. So the number of change ideas needs to be decreased in the next set of QI projects which we did. And the last one is, it is possible to translate the learning from the QI project which we did to the other geographical areas of the same one. Thank you. The last one, I think that's the last one. Next slide, or the last one. Oh, thank you. That's it.
Great. Thank you so much, Sen. That was really great to hear. So thank you for giving that. It's a really important topic, that kind of waiting times in mental health services. We'll just check to see if we have any questions in the Q&A section, or any questions here in the chat. It says here, Katie has said, it looks like the biggest change was an increase in staffing. Sen, would you like to comment on that at all?
Yes, thank you. So a significant change is that I do understand, because only one clinician was there to begin with. We increased it to 3, so that by itself would actually make the change. But the processes were streamlined across both Bedford and Luton through the QI project, or the learning from QI project.
Fantastic, thank you. I think Naomi's just going to check as well if there's any questions in the Q&A section. We'll just have a look.
I'm having a look now. There's no questions on. Oh, there's just popped a question. Okay, so we've got somebody saying the data was 2016 to 17. The changes are great. Have you been able to maintain this? A lot has happened in the last few years.
That's correct. Yes, we fortunately we are able to maintain it. But whenever we take our eye off the process and the streamlining, we understood that there were slips in the process. So at present, the last time when we looked at it was 6 weeks from the referral to the diagnosis. So this was looked up in 2019.
Right. Okay, that's brilliant. Any other questions? Right now, we will have time for the Q&A after the last case study as well.
Thank you.
Okay, so we're just looking at the time, and it seems we've got 5 minutes left of what we told you in terms of this being an hour-long webinar. Would people be able to respond in the chat whether they want to see the last case study by Maureen, which is about care planning, or would we like to just go straight on to questions so people can ask all the panelists anything that they would like? If people can just answer in the chat and we can have a look. So someone's saying last case study. Okay, keep going with the slides. Okay, so it looks like most people want to see the last case study. So, okay, so we'll pass it over to you, Maureen, and then we will have Q&A after for about 10 minutes if people can stay. So here you go, Maureen.
Okay, thank you. So I'll be representing on behalf of a team in the Sally Sherman ward at East London Hospital, and their work was around increasing care and family participation in care planning. So next slide, please. So in terms of going back to the model again, the presenting problem was that family and carers weren't coming to the care planning meetings. And in order to kind of work out what to do about it, that's the second part of the first question, which is the diagnosis. So what they did was that they sent out a questionnaire to families and carers, asking them the reasons why they weren't attending, and a variety of different problems came back. Sometimes people were saying that they didn't know the meetings were taking place. Some of them said that although they knew the meeting was taking place, that they were forgetting, and some felt that the meetings were taking place at times that didn't really fit in with the kind of other commitments, so they weren't able to attend. So a variety of different factors that could be addressed through improvement methods. They then, so the cursor doesn't seem to be moving on to the slides to show people. Yeah, okay. So if we just move on to the next one. So they set their aim, and their aim was to increase family and carer participation by 90% in 12 months. Now that seems really, really ambitious, but as you'll see when we get to the run charts, they did a good job of estimating. In fact, they underestimated what they were able to achieve. So if we move on to the next slide, just to kind of talk about some of the other parts. The question 2, the outcome measures. Interestingly, with this project, they have 2 outcome measures, so no process measures, no balancing measures. So the first outcome measure related directly back to the aim. So their aim was to increase attendance at the meetings. So they were measuring the percentage in attendance at meetings. But what they also recognised, or they believed, the hunch was that if they increased attendance at meetings, they would also increase the percentage of the care plans that were being reviewed and signed by family and carers. So in a way, a kind of a side benefit of that they thought was worthwhile measuring. Move on to the next one, we can hear about what they did. So in terms of kind of people not knowing that the meetings were taking place, they organised coffee mornings to advertise it. They created leaflets and posters to tell people about the meetings. And in terms of people forgetting the meetings, they set up reminder systems to let people know when the meeting was coming up. And around the problem of people the timing not working, they worked with families and carers to identify the best times, and they offered one-to-one focus group meetings as an alternative to that as well. So if we move on to the kind of, this is an interesting slide. So here's 2 run charts. There's SPC charts actually, but run charts are just as useful when you're looking at doing improvement work. What they show here, so the one on the left-hand side is the first outcome measure, which is the percentage of carers attending the meetings each month. And you can see at the left-hand side of the charts, their baseline was about 11.5%. So about 11.5% of meetings had a carer in attendance. By the time they got to the end, they were up to virtually 45%. That represents a 290% increase. So their target of 90% was actually lower than they actually achieved, which is a fantastic piece of work. So the second one, again, they were right. So they predicted that the percentage of care plans reviewed and signed would go up as well, and it did. It went from 40% up to 100%, which represents a gain of 115%. So a fantastic piece of work. And just to kind of quickly share, next slide, some of the learning that they picked up along the way. They were surprised at just how much the carers valued the opportunity to actually get together with each other. And also the fact that there was an increased attendance at meetings, the relationship between the staff and the carers really improved. And interestingly, they could have used this as a process measure, but they didn't. But they found that there was actually a decrease in complaints. So as the kind of contact between the staff and the carers grew, complaints went down, which is a lovely unintended and unanticipated benefit. And kind of more general level, a couple of reflections were from the team that it's really important to make sure you got the right skills mix, because as you can see, the kind of ideas that they were testing out, lots of different skills needed to develop those change ideas and test them out. And finally, and a really, really important one to end on, so important that the project needs to be owned by the whole team. It's not just a case of it's them over there that are doing it, because this is a whole ward situation and the whole team needed to be involved. So really exciting piece of work, lots of learning from them as well. Thank you.
Okay, fantastic. Thank you, Maureen. That was really good. We don't have too much time for the quiz, but hopefully we can come back to that perhaps later after the Q&A. So we'll go straight onto the Q&A now. We had a few questions sent in before the start of the webinar, so we'll have a look at those and then prioritise raised hands afterwards. So the first question that we had here was from a senior psychologist of Cumbria, Northumberland, Tyne and Ware NHS Trust. And they've asked what criteria was followed to audit the inpatient's clinical population, especially for the delivery of psychological therapies. Unfortunately, we didn't manage to get much context or clarification on whether this is for the core audit or the spotlight audit. But I'll pass this over to perhaps David or Lorna, who might be able to answer this question.
Well, I'll start. You'll remember that the criteria for inclusion in the audit that you were an inpatient aged from 16 upwards with a primary diagnosis of anxiety or depression. Obviously, a number of people had comorbidity, and that you were receiving inpatient care during that 6-month period in 2017. So that was how people entered the database. And then in terms of the psychological therapists, we actually looked at very simple markers in the core audit, which was just, the proportion of people that were referred, the time that it took to be seen, whether it was individual or group, a bit of the nature of the group, and whether or not that accorded with current NICE recommendations. I don't know if you want to follow up on this, Lorna.
Sure, thank you, David. I can see in the chat actually that there's a comment that this question was in relation to the Spotlight audit. So that's just come through, so that's helpful clarification. In the Spotlight audit, we did include a wide range of different types of services, and we recognise that there are limitations associated with doing so. Within the Spotlight audit, we weren't able to use different criteria or take account of the implications of different types of services. So the same methodology applied regardless of what type of provision there was. Obviously, the context in which the findings and recommendations are considered will be important to take account of at a local level. And some of the inpatient implications for the Spotlight, there may be direct cross-referencing that you can do with the core audit that's specifically focused on that inpatient population. So as David was saying about the proportion being referred for psychological therapies in that context.
Great, thank you very much.
Yeah, okay, so the next question we have that was pre-sent is from a clinical quality facilitator at Northamptonshire Healthcare, and they're asking, what if your psychology service is embedded within teams rather than a standalone psychology service? We didn't manage to get more context to that, but we think it's in relation to starting up a QI project. Is there anyone who'd like to answer that question?
I mean, I guess one thing is, if you're working within a CMHT and you're the solitary psychologist, it would make sense to establish links with the psychologists in other CMHTs within the same trust to see if the concerns that you have are shared by others, and then to work in a unified way across the trust as a whole. Lorna, I don't know if you want to comment on that in more detail.
Yeah, and I'm also wondering if Maureen might want to come in here as well in terms of the steps that you go through in developing a QI project, because to me this would be very dependent on what it is that you're trying to do and how you think you can go about achieving the change, whether that's at a service team level, or whether you need to think about your psychology provision on a wider context as well. So some of that would be informing what steps do you take to actually get things off the ground.
Fantastic, thank you. I think we might have just had a slight technical issue with Maureen. It seems that her video is frozen, but hopefully she can join us again for the rest of the questions. We've got another one here from pardon me, a consultant psychiatrist of North West Boroughs Healthcare NHS Foundation Trust. They've asked discharge against medical advice and discharge brought forward by the patient were not considered in the toolkit, and does this mean that this has produced potentially flawed results? Is this one that potentially our clinical advisors might like to take? Or Sen, you can also
Okay, I mean, my feeling about this is, I mean, thank you first for the question. We didn't specifically look at discharges against medical advice, which we know thankfully are only a small proportion of admissions. Discharge brought forward by the patient is actually quite a hard thing to study, because you may not know that it has been brought forward by the patient. We do know, though, that from studies looking at the risk of suicide after discharge, that people who discharge themselves against medical advice do have a higher risk of suicide in the subsequent 6 months. So in a way, a discharge against medical advice is a failure of care, and we need to think very carefully about factors associated with that. We have looked at that a little and found that the proportion of people who seem to be discharged with little notice was somewhat higher if someone had a comorbid personality disorder or a comorbid substance and alcohol use disorder problem. Papers arising from this analysis have been submitted for publication. But certainly the group of people that discharge themselves against medical advice are at increased risk after discharge.
Right, thank you, David. That's a very interesting answer. So now we'll look at our final question from the pre-sent questions, which was from a consultant clinical psychologist of East London Foundation Trust. And they're asking, could you highlight examples of good practice in engaging honestly and constructively with service users about waiting times? And not... oh, yeah. Lorna.
I'm happy to pick up on this question here, and thank you for asking this question. It is really important that we can have open and honest conversations about waiting times and being able to try to communicate as much information as possible at the earliest point possible. So ideally, at the time of assessment, the clinicians would be aware of what the waiting times are and be able to talk that through, acknowledging if there are long waits, some of the difficulties associated with managing the wait, direction to sources of support during that time, and expectations around any communication. So sometimes services might have systems in place in which they provide regular updates or provide contact, perhaps on a monthly basis, to check in. Also, sometimes there can be implications in making choices. Maybe there are choices about which type of service or the format of therapy. Sometimes it may be that group therapy could be accessed more quickly than individual therapy, for example. But again, it's really important to be able to openly discuss that and to be able to collaboratively make a decision and think through the implications of that decision.
Can I add one point, just one point? In the current context of the COVID-19 pandemic, our waiting times are going to go high. For example, for the memory services, because all the non-essential services we have kind of cut down, and we have written a clear letter to inform them exactly what's happening, because as you mentioned very clearly in the question, we have to engage honestly and constructively with the service users so that their satisfaction is guaranteed at the end of our processes.
Great, thank you, Sen and Lorna. That was really interesting. Those are the end of the presenting questions, and there's no more QA questions that I can see, or less. Sorry, there's just one popped up, I think, on the side here. Naomi, are you able to see that Q&A question?
Yeah, this is the one from before, which
right.
is kind of commenting on Sen's results.
Okay, no worries. And we'll just have a check in the participant box to see if there's any raised hands. So if you raise your hand, we'll be able to turn on your mic if you have any questions, and you can voice that to our panelists at all. So let us know if you have any questions in relation to any of the webinar at all. Okay, no raised hands at the moment. So if that's all, please do feel free to also send us in any questions that you think might have come up afterwards. So yeah, please do get in contact via our email address that we'll put on the last slide as well. Varsha, it'd be useful to get a contact for any queries. Yeah, absolutely. So we can send you over the contacts of our panelists today, if that's okay with them, and put you in contact if you need any more support. The link to the slides will be sent via the email that you've signed up with for the webinar today. So that will all be sent to you, as well as the actual recording of the webinar today as well. Okay. So thank you all for joining today. It's been really great to have you all here. I hope you've used this opportunity to share some ideas and potentially become inspired by some of the case studies that you've learned. And we hope you found this session really useful in terms of kickstarting some of your QI planning.
Yeah, thank you very much. Thank you to all the panelists for being with us today. And we hope you feel all more confident to go back to your trusts and start some QI plans.
Thank you very much.
Thank you very much.
Thank you very much, Lorna, David, Sen and Maureen. If you'd like to continue discussing some of the questions here, we'll be online for a few moments afterwards, but I think we are sort of closing up soon, as we have ran a little bit over time. Also, just to mention that we do have an online platform for you to continue sharing ideas around QI, and that's called Knowledge Hub. So I'll just post into the chat now the link to that. And if you search for NCAAD, NCAAD, you can join the NCAAD group and continue to share ideas. So hopefully that you find that really useful. As I mentioned, we will also be sharing the slides today and the recording. Just to mention also, we will have a second webinar coming up on the 12th of May. So hopefully we'll be happy to see you all in attendance there as well. We do plan on including some more case studies, and we actually have a feedback form that you can view after the close of this webinar, where you can voice what you'd like to see in the second webinar. So yeah, if you could all make use of that, that would be great, and let us know how you found today. So thanks again all to coming. If you have any questions, again, please do get in contact. And thank you to all our clinical advisors, the NCAAD team and the QI experts. And see you hopefully on the 12th of May. Thank you for joining.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.